Hello and welcome to the Federal. I'm S. Srinivasan and I'm joined by Venkat Raghavan, who's our data editor. Today we have with us Dr. Christopher Murray, a very special guest. He is director at Institute for Health Metrics and Evaluation, IHME, at the University of Washington. IHME, in a short period of time, has emerged as gold standard for understanding topics related to health and development. Professor Chris is a pioneer in the field of global burden of disease measurement. His projections on COVID-19 infections and death are closely followed worldwide. Thank you, Dr. Chris, for taking time off to be with us on the show.
Very happy to be here.
Your latest projections for the globe and particularly India paint a grim and alarming picture. IHME projections suggest that the cumulative deaths caused by coronavirus globally is at variance with what is being projected officially by various governments. What are the factors that define this?
Well, we've looked at all data that comes on the death rate and compared the death rate as observed from all causes to what would be expected in a given week or month based on what happened in previous years. And through that, we get a measure of expected mortality. And then we can look at how much more deaths there are. And that gives us an insight into the total COVID death rate. And that number suggests, the underreporting of death varies by country, largely as a function of testing. But that number suggests that there's been about 6.9 million deaths in the world already from COVID. And so that's, more than double the official numbers.
Yeah, as far as India is concerned, I think your projection is 3 times as far as, if you look at the latest, current figure, the study suggests that the current surge, which is described here as a second wave, would hit a peak somewhere in 3rd week of May. But your projection is now 3 times.
Yes, based on how much, it's a little different by each state in India, but in aggregate for India, it's 3 times. And that's really largely driven by comparatively low testing still in India compared to, for example, high resource settings. And that contributes to this, essentially 3 times the official numbers. It does suggest that the true death toll per day may get up as high as 14,000, 15,000 deaths towards the end of the month.
Okay, so have you also taken into account in your modeling the factors such as whether it is spreading to rural parts of India?
Yeah, what we try to do, we have models for each state in India. So the trajectory all through the pandemic has been different. For example, Delhi has had much more infection than many other states. In fact, some of the seroprevalence data suggest even before this surge, 70% or more had already been infected in Delhi. The numbers are much lower in some states before the current surge. But we make a model for each state. We take into account in that model the key drivers of transmission that we know about from around the world. So that's how mobile people are, how much they're interacting, and we use cell phone data to try to get a handle on that. Mask use, which is an absolute critical determinant of transmission. The social distancing mandates that different state governments and national governments put in place. So some states have social distancing mandates, as you know. Others have had much less in India. Then in addition, the testing rate, because the more you test, the more likely you are to find people sooner and extract them from transmitting to other people. Vaccination rates, because that's a very powerful tool, as we know right now. Seasonality, a thing that we've learned in studying COVID for more than a year, is it's very seasonal. And so like influenza, it's worse in certain seasons and it gets better in other seasons. And so we build in seasonality. And so that varies by the latitude of different states in India. And those factors are the main ones that go into modeling. The last one, of course, is the newest, in the sense that since January, we've recognized that new variants are very important. So we saw the B1351, the South African variant, drive an epidemic in South Africa and neighboring countries. We've seen the Brazilian or P1 variant drive a huge epidemic in Brazil and neighboring countries. And we saw a surge in Europe from the B117 variant. We suspect strongly that a lot of what's going on in India in April is the B1617 variant, the so-called double mutant. More transmissible, also can reinfect people that have been previously infected, and probably means the vaccines that are available are less effective against that variant. So all that goes into our model, and that's how we come up with trying to understand the current surge. And I think the good news, if there's any in this story, is that we think that transmission may be peaking about now. And then we'll start to come down, but that still means we have about 3 weeks of deaths still going up because of the lag between infection and death.
Okay. Sorry, Venkat, go on.
Professor, so your last report on May 1 said that about 40% of the population could have been infected. And even now you mentioned about, the case of Delhi where infection rates were 70%. Now, we had this theory, at least way back in September, October. We also had the Sweden example talking about things like herd immunity, both vaccine-induced herd immunity as well as people who are getting infected. Now, in the context of this variant, does any of those theory at all make sense, or do we have to recalibrate?
We've been saying for many months since January that the advent of what are called escape variants, and they're called escape variants because there's immune escape. You can get reinfected even if you've had a previous infection, or the vaccines are less effective. So there's immune escape, and this is P1, B1351, and we also think very much B1617, the variant, the double mutant in India. Why is that so important? Well, an escape variant means that it doesn't matter if you've got 70 or 75% already infected. You can get many people reinfected. And in fact, from what we understand from P1 in Brazil, probably these escape variants, being 70% of people who've been previously infected can get reinfected. Could be even worse than that. So that means there's a lot of people who we thought were immune are still able to be infected by these new variants. And that really changes all the thinking about, quote, herd immunity. It's very hard to achieve. It's going to be variant specific. And we've also seen in many places, Delhi's not the only one, but we've seen places in South America, Amazonas state, Mexico City, some parts of Peru and Ecuador, where 75, 80% of the population is infected, and still there's an epidemic. And it's because of this, you need a lot of immunity to get to herd immunity. It's a very transmissible bug. But secondly, these escape variants just rewrite the rules about herd immunity.
Yeah, so on this escape variant, which means, in other words, what you're saying is vaccine could be less effective. And also there is saying there's no protection for previously infected. For that, it requires probably a lot of, genome sequencing. And you are saying that you're not 100% sure whether, sequencing is being done to that extent. Somewhere in some other interview I read. But have you taken these into your modeling? Because this may vary your estimates.
It certainly could. I mean, the only way to explain what we're seeing in Delhi, as an example, is through an escape variant, because you had 75% or 70% already infected. There shouldn't have been a big surge. So that tells us, even though there isn't great sequencing, we don't have as much data as we do in the UK or in Europe or the US. it tells us there's an escape variant playing a role, at least in Delhi. Secondly, we're seeing this surge all through India. It's slightly staggered, but it's pretty much everyone taking off in the month of April. So it makes it very unlikely from our point of view to see such an explosive surge, but different causes in different parts of India. It's possible, but unlikely. It's like you see the same thing happening everywhere. Especially when it's not the winter season, you're coming out of essentially your northern hemisphere, or most of India, and you're coming out of what should have been, progressively less transmission. So the fact you're having an April surge all at the same time makes us think that there is an escape variant, even though the sequence data isn't there to fully confirm that, that's driving this in most of India. It's very hard otherwise to put all the picture together as we see the data.
Yeah. Okay.
Professor, as a health economist, how do you look at NPIs in this present context, especially considering the trade-off in a country like India, where a complete lockdown? If you go by the IHME, it's completely inevitable. But what are the trade-off left? What are the options that are left to policymakers in the present context?
I think we've always, few reflections. First, we've learned through the pandemic that the social distancing mandates do work. Now, the question is which ones are the most impactful, and which ones do you use to minimize the economic harm and maximize the health benefits? So the things that we know where, first of all, getting everybody to wear a mask. That's just should be absolutely the first thing. There should be a mask mandate. There should be penalties if you don't wear a mask. So, and we've learned that over and over during the course of the pandemic. It's enormously important. It doesn't impede economic activity essentially much at all. Next, we've realized that a number of some school closures in some countries, secondary school or higher, are helpful. Restaurants, bars, cinemas, where large groups get together, clearly contribute to transmission. And essentially any gathering more than 5 or 6 people is a real risk for transmission. If you manage business so that people are masked, socially distanced, that can be okay to keep businesses open. So I think it's fine-tuning which mandates and where. But when you get to the point where transmission is, a straight line up, at that point, we would have said, even 3 weeks ago, we would have said the sensible thing to do, because you could see what was coming in terms of the death toll, would have been, to really have a sharp shutdown, because you could have prevented, we're talking about hundreds of thousands of lives that have been lost and more to come. So I think, you can, if you're in the ramp up phase, you can use the social distancing mandates in a more nuanced way. Once you get to the explosive transmission phase, then you need stronger action. Now, at this point in India, it's possible that things are peaking because you're running out of people to infect. Because, a very small fraction of infections are being currently detected, probably only 3 or 4%. So the official case numbers, you've got to multiply by 30 or 25 to get the true number of infections. So there are millions of infections, we think, per day. And that means you are quickly going through the whole population and infecting those that are likely to get infected, so that by the end of May, you will have a very small number of people still at risk of getting infected. But of course, the death toll from that is going to be very large.
Yeah, I think, Professor Chris, that you are every week actually revising it. Last week you said 20, times. Now, today you're saying 30 times. It's getting even more alarming. But let me ask you a different question. Let's come to the effects of vaccination. In India, so far, only 2% of the population is fully vaccinated, and another 12 to 13% has received a single dose. If herd immunity is not working, escape variant is lurking around, then managing pandemic becomes even more challenging. Like you said, the business have to go on, like Venkat is suggesting. How do you see this problem as an expert? What would your recommendations be? How much of population need to be vaccinated? What do we do now?
I think, despite all the new variants, the best tool that we have right now is vaccination. For absolutely. I mean, look at Israel, look at England, look even now at the United States, where vaccination rates are getting high enough, that you are seeing a marked effect on transmission. Israel is almost down to 0 cases and deaths. It's very low numbers, very dramatic effects. And even in the presence of at least the B.1.1.7, not an escape variant, but a highly transmissible variant. And even when the escape variants come around in a setting where people are highly vaccinated, you are going to have some transmission, but the effect in terms of death and hospitalization will be dramatically less. And so even with the escape variants, vaccination is going to be very, very helpful. So as a strategy, getting more people vaccinated, particularly the people over 60 who are at greatest risk of death, is a hugely beneficial immediately to prevent, further harm. And then as you get, a decent fraction of the population vaccinated, maybe 50, 60%, although the number may be smaller in India because so many people have been infected by the end of this month, you will then add to your ability to prevent, wide-scale transmission if another variant comes around in the future.
Okay, so you're saying even if there is an escape variant, if one is vaccinated, it offers some kind of protection still. Hospitalization may not happen.
Well, it depends on the vaccine, unfortunately. So we know, there's limited evidence on the escape variants, direct evidence. We know, for example, that in trials against the South African variant, the B.1.351, which is an escape variant, that the Johnson & Johnson vaccine was about 70% effective for severe disease, or in the high 70s, and for all disease, closer to about 60. We know that the AstraZeneca vaccine, unfortunately, was only about 10% effective against B.1.351. There is some hope that it was more protection against severe disease, but there isn't really great evidence on that. And then the mRNA vaccines, the most effective in general, there was a recent study actually today suggesting that they may be about 70 to 75% effective for infection, but much more effective for severe disease, even for the escape variants. So that's very encouraging that the mRNA vaccines, even without the booster that they're making, is still pretty effective against the escape variants. And then you have this sort of tiering down, the less immunogenic vaccines down lower, and then at the bottom of the list, so far as we know, is AstraZeneca.
One thing which is important, two questions I want to ask. You have done this across the globe. It's not just India. And your latest number, which you released this morning, says a new table of top five, which you have released. The topping the table is the United States, after that India, and then there are other countries. Now, when you are comparing countries, let's take two extremes. One on the one side is Japan, on the other is Egypt. Japan may not be like one reason you said is that if testing is not done enough. I think Japan is doing quite a number of testing. So Japan is on the one side, which is probably you actually said 100,000, whereas they are claiming 10,000 deaths. So again, the range is wide. So what are the differences? Where are the differences coming from when you have such a large, wide spectrum available? Where are these differences coming from? and how do they vary across countries? How do you look at it?
So I think there's several factors that have gone into this problem of underreporting. So one is testing. That's the most obvious. And a country like Mexico that has been very underinvesting in testing remains, that's one of their biggest challenges. Second problem was, especially early in the epidemic, people were not paying attention to the elderly, at least in the high-income countries where elderly often were in, older care facilities. They weren't testing them. And it turns out, with hindsight, many people died from outbreaks of COVID in those facilities, and many of those deaths went unrecognized, even in high-resource settings. But even when you take those factors into account, there are some places in the world where the underreporting rate is incredibly low. So, or underreporting is high, the reporting rate is low. Egypt is an example where maybe less than 1 in 10 deaths from analyzing their own mortality data are being reported. As a region, the problem of underreporting is the greatest in Eastern Europe and Central Asia, far worse than in India, where many countries we're only seeing 1 in 5, 1 in 6, 1 in 10 deaths actually getting officially reported. And that's not simply a testing issue. And so it's probably to do with medical practice in terms of how they fill out the information, where we think it's really the only explanation that people are much more reluctant to put down COVID and report a COVID death. And so we're seeing, very marked underreporting. The Russian case is interesting because, the official government numbers about underreporting are very similar to ours. Rosstat, the statistical agency for Russia, has a number that's very similar to ours, about 1 in 6. Are being officially reported. And so you have one statistical agency saying that there's 6 times more COVID death, and then the Ministry of Health saying a different number. So clearly there's something else going on. And the finding that we have of these huge underreporting is also backed up by their own seroprevalence surveys that show very high % of the population that have been infected. So there are other factors that go into this underreporting. It's not just testing, and I think some of that is sort of essentially medical culture or reluctance to report COVID deaths. Now, Japan is interesting as a specific case. There's not as much COVID in Japan, so it's a bit harder to get this measurement right. You look at their all-cause mortality, it does appear like there's much more death than is officially reported. I think you're taking a number divided by a small number. Is it 10? Well, maybe it'll turn out to be 5 or 6 as we get more data coming in, as more months of the epidemic goes along. But there is certainly more underreporting than simply the testing would suggest.
Yeah, actually, it's a bit. Were you surprised when you looked at the data for Brazil and Iran that actually it is not so underestimated?
Very surprised. I think in some states in Brazil, there's almost no underreporting, and in others, some of the poorer states, there's ratios that get up towards 3. But as a country as a whole, markedly less underreporting. Now, there is there's a long tradition in Brazil of very open statistical reporting. They actually have quite sophisticated, impressive statistical systems, and they've had a commitment for 10, 15 years of a lot of data transparency. So they put online their data sets. It's really quite impressive. They've had great struggles putting in the NPIs in Brazil, but one thing that they've done a better job on is some of the data systems. As the epidemic has gotten very bad, the reporting has gotten worse. So we also do see this phenomenon that underreporting gets worse when the healthcare workers are just overwhelmed trying to take care of patients.
Yeah, so I have a particular question about India. Coming back to India, here, what you have said is you looked at the figures of last year, COVID 2019, when it's 2020 when it happened in India, monthly figure, weekly figures, and then the estimates have come even up till April. You have taken those data, and then you also in the new modeling, perhaps you also taken into account the deaths that happened 3-4 years ago. Have you taken in that also? How different this modeling is then? As far as India is concerned, what are the various factors you saw which made you arrive at this large number?
Yeah, I mean, there's some, India, the data are not as strong on all-cause mortality and certainly not reported as a regular basis. So there's data for certain jurisdictions that is better. There's a number of smaller scale studies. Now, the smaller scale studies, particularly the ones recently, have been suggesting much higher multipliers or worse underreporting. I'm sure you've seen these reports of analyzing crematoriums and suggesting maybe the true number is 5 times higher than the reported number. But we've tried to look at all the data that we can find, look at the testing rates in India, and that's where we come up with our number of about 3. Now, one of the challenges in this is when you look at excess mortality, how much of that excess is COVID? How much of that excess might be people, avoiding going to the hospital or the clinic because they're afraid of getting infected, and therefore they're dying from causes that they didn't get treatment for? How much is the reverse? How much are we underestimating looking at excess mortality because we know flu is down, we know some other viruses are down. We also know that injuries are down because mobility was being down during the pandemic. And so at the global level, injury deaths are down about 5%. And, depending on when you look in India, back in the strict lockdown in April last year, probably injuries were down quite a bit in terms of road traffic injuries, other types of injuries. So there's a lot that goes into this, that could move that number up or down. And so there's certainly a lot of, there's quite considerable uncertainty. So if somebody comes back and says to us, the true number was not 3 times higher, but 4 times higher, I wouldn't be much surprised, nor would I be that surprised if it came out to be 2.5 times higher. So I think one has to recognize that we're all trying to make sense of quite messy data in real time as it comes in during the pandemic.
Yeah, so here is a question for you, Professor, as somebody who's estimating, and I feel that maybe some risk involved in predictions, estimations rather. Because you're constantly questioning the credibility of data provided by various governments, including Indian government. And, like for instance, did IHME erred in overstating the position as far as the United States was concerned? I'm taking you back to March 31st, 2020, when White House put out a chart prepared by IHME to show that pandemic was rapidly winding down. But what happened was just the opposite. The epidemic actually spilled over, really grew in June. Similarly, it could happen in India, where serosurveillance, most of us thought, the report showed that there is a widespread infection and therefore there would be herd immunity. And now that again is being challenged now. That theory itself is being challenged. There are so many risks involved. So, and you're a pioneer in this. So your profession or the estimation which you seem to be full of risks. How are you managing these risks yourself?
It clearly, this virus teaches us a lot of humility because we keep getting surprises. So, for example, back in December, we were all thinking about vaccination and who would get vaccinated and how that would affect transmission. And then suddenly it's all about the new variants that we didn't see coming. So there are as many things that have happened in the course of the last 14 months that keep us, guessing as to what's coming next. Some factors we've just learned a lot about. So if you go back to March, we very accurately, within a day, predicted the peak in the US. We said April 16th. I think the peak was April 15th. But what our models said is that if you did kept the lockdown in place to the end of May, you would largely have the epidemic under control. And you could have managed, like Australia and New Zealand and Singapore, you could have managed the rest of the epidemic by micro testing, contact tracing, quarantine. What we didn't factor in the original models for the U.S. is the political drive to just not see the job done. And worry about the economic effects, such that there was this rush in the end of April to open up in some states, and basically that made it impossible to get the epidemic under control. With staggering economic and human costs, if we had stuck to another 4 or 5 weeks of lockdown, very likely we would have had it under control. So I think we've learned that it is the biggest factor, or one of the biggest, up until the variants, probably the biggest factor, is the behavior of government. Their willingness to put in place the NPIs, their willingness to stay the course and get things under control. And then we've now learning in this phase of the epidemic, it's not just what governments do, it's also what people do. Their willingness to keep a mask on when, what happens is when the numbers are going up, people get scared, they start wearing their masks, they start being careful. When the numbers peak and start coming down, they change their behavior, and then that just brings it. So we get this roller coaster. It goes up, it goes down, goes up, it goes down because of the behavioral response of individuals and governments. And I think that's the biggest, lesson, that our job of forecasting is both about all the sort of biology of the disease, the efficacy of the vaccines, the role of new variants, but it's also about trying to predict human behavior, and that is challenging.
That's very difficult.
Very difficult. Are they willing to get vaccinated? Will they keep wearing their mask? Will they be cautious? Will they protect their parents and not interact with them or put them at risk? All those things that go into what we have seen work, where it's done well, and we keep learning. So
what about? Yeah, sorry, I'm cutting in. Sorry. What about the? We are already panting when we are in phase 2. And there is a talk of phase 3 somewhere in winter in the United States. I don't know when it is. Indian scientists are also saying that it's expected in India also. Where do you see that? What is your estimate on that?
This is the big question in the high-income world, who have the luxury of a lot of vaccine that's available. And so there's a view of people that says we will. COVID's over, right? So there's real risk that people think in North America, in Europe, that by the summer, COVID will be gone. We'll have vaccination, past infection, we'll get to herd immunity, and we can just go back to our lives. Our models, when we run longer range models, there's a very real risk of a return next winter, in the Northern Hemisphere winter, because there'll be enough people that haven't been vaccinated, and amongst those vaccinated, there'll be enough people who can be infected with the escape variants, and that'll be enough to have transmission come back around. And that will be combined with the fact that people are not going to be cautious. They won't be wearing a mask. They won't be being careful. And so I think there'll be a big surprise late December, or probably mid-December, late December, where we will see a further surge in the Europe and North America. Now, in places without as much access to vaccine, it's a bit more complicated, because what may happen is we'll have a surge sooner, and more people will get infected. But we do see that, as you'd expect with a seasonal virus, that in each part of the world, in the northern hemisphere, including India, we would expect winter surges. In the southern hemisphere, the reverse pattern. And then it'll also depend on what new variants come along. So we certainly don't think COVID is over past the summer. We think we'll be dealing with it well into 2022.
Yeah, I have a final question. India has demanded that patent protection, so the vaccine recipe should be lifted, and I think Biden administration is agreeing to that. So what are your views on that? Will it speed up process of vaccination? What's your view on that?
It would be a great thing if more people can get access to the highly effective vaccines, particularly the mRNA vaccines, which so far have proven to be the most effective. So that's a tremendously positive step. The challenge will be how quickly it happens and how quickly the manufacturing of quite complex vaccines, with a technology that is relatively new, can be disseminated. But clearly, in the mid to long term, our best strategy is vaccination, combined with people being cautious when cases start going back up again. I think the exciting thing about the mRNA vaccines, which is why getting the everybody access to them is so important, is that boosters can be made pretty quickly. So we've already seen Moderna making a booster for B1351. Hopefully soon they can make a booster for B1617. So if the vaccine makers can keep up with the new variants and then disseminate that around the world, that can really make a difference as we battle COVID, into next year or maybe even beyond.
Yeah. One final question, Dr. Murray. When you look at these data, and some of them are very frightening, and when you looked at the data of Brazil some time ago, you made a comment saying that I couldn't sleep that night. But and this may be happening to when you look at data across the world, for instance, now Indian data or other data. How do you cope with that?
I was very concerned about, just when we started to recognize how big an issue these escape variants might be. And yes, I couldn't sleep at night for a few nights just thinking about the implications, because I, like many, thought in December that we would see COVID behind us. It would take longer for the low resource settings, but within 12 months, we would largely have seen COVID behind us. I no longer think that's the case. And now I think this devastating epidemic in India is very concerning, because I think you can't explain it just by behavior. It has to be a variant, and most likely B1617. And if it's a variant, that means that variant is not only having this terrible toll in India, but likely to spread in the region and globally. And so I think we are going to be living through each of these new variants when they appear, and how we tackle it. So I unfortunately for us all, I think we will be talking about COVID for many months to come.
Thank you, Dr. Christopher Murray, for your time and explaining us the whole process and taking your time off to explain everything to us. Thank you.
My pleasure. My pleasure.